Hi, this is Lauren Miller, and today I will be talking about small bowel obstruction. I'm going to start with my pants question number 1. A 60-year-old white male presents to the ED with fecal vomiting for the last 5 hours. He reports obstipation for 4 days, as well as cramping, intermittent abdominal pain, and distension for 6 days. He denies fever, chills, weight loss, or changes in mental status. An upright abdominal x-ray reveals air fluid levels in a step-ladder pattern in addition to dilated loops of bowel. He was diagnosed with having a mechanical bowel obstruction and was moved to the surgical floor. Which of the following is not a significant risk factor for the development of small bowel obstruction? A. Post-surgical adhesions. B. History of Crohn's disease. C. A history of foreign body ingestion. D. GERD on PPI treatment. Or E. A history of abdominal wall hernia. My second pants question is a 36-year-old white female presents to the ED with abdominal distension and constipation for the last 5 days. She is nauseated but denies any vomiting. On physical exam, she is tender to palpation in all 4 quadrants. She is afebrile. She has a history of Crohn's disease and is status post 2 months a right hemicolectomy. Which of the following would you expect to see in an upright abdominal x-ray? A. Auroral sign. B. Air fluid levels in a stepladder pattern. C. A mass in the descending colon. D. Apple core lesion. Or E. Diffuse hazy gray appearance in the right upper quadrant. Moving on to the case study, this patient was a patient at a Kindred long-term care facility in Webster, Texas, treated on 10/5/2015. He was a reliable source. His chief complaint is that his stomach is really distended in his HPI. So patient BD is an 81-year-old white male complaining of abdominal pain and distension, obstipation, and fecal vomiting. He's been hospitalized at a Kindred LTAC for the past 3 weeks being treated for pneumonia. His past medical history is significant for COPD, hypertension, coronary artery disease, iron deficiency anemia, tubular adenoma, reflux esophagitis, and incisional hernia. He states that his abdomen has been increasingly distending over the past 6 days and has not had a bowel movement in 4 days. He reports his abdominal pain is generalized to all 4 quadrants, is colicky in a 9 out of 10 on pain scale, and it has worsened. He states he started vomiting boluses yesterday and has not been able to pass gas for 3 days. He denies fever, weight loss, diarrhea, oliguria, xerostoma, or a localized abdominal pain. His past surgeries include a sigmoid resection from a tubular adenoma complicated by an incisional hernia 5 years prior, no known drug allergies, no social history, and no significant family history. Medications for GI include megestrol acetate, ciprofloxacin, lactobacillus, ondansetron, clopidogrel, aspirin. Vitals are normal, heart rate 76, respirations 14, oxygen stat 100, temperature 99, blood pressure 126/70. On physical exam, he is alert and oriented ×2, well-developed, well-nourished male, mild distress from pain, on oxygen and afebrile. Musculoskeletal and neuro exams were both unremarkable. Cardiac, regular rate and rhythm with a distinct S1, S2, no murmurs, rubs, or gallops. Respiratory CTA on left, crackles on the right lower lobe, equal chest wall expansion, and he's on oxygen. Abdomen, distended times all 4 quadrants, tender to palpation in all 4 quadrants, and he has a tinkling gaseous sounds in his epigastrum, left upper quadrant, and right upper quadrant. Lab work, white blood count is 12, hemoglobin, hematocrit 8.3 and 28.2, platelets 396. Electrolytes were unremarkable. Iron, ferritin, albumin, and liver enzymes were all normal. Imaging, an upright abdominal x-ray reveals an air fluid levels in multiple dilated loops of small intestinal bowel. Assessment, he was diagnosed with an unspecified intestinal obstruction of the small bowel. He has iron deficiency anemia that's unspecified, a personal history of colon polyps with a sigmoid resection, and incisional hernia without obstruction and without gangrene, in addition to severe COPD, hypertension, coronary artery disease, and reflux esophagitis. The plan was to order a CT to confirm a small bowel obstruction and to rule out cancer masses or mechanical causes. Consult general surgery and move him to the general surgery floor. Treat functional small bowel obstruction conservatively and educate the patient on any signs of emergency, such as fever, oliguria. Rule out differential diagnoses, and then he will be NPO and nasogastric suctioning for decompression, continue IV fluids, recheck lab work, recheck upright abdominal x-ray, and begin opioids for pain. So moving on to my disease sheet, small bowel obstruction, etiologies and risk factors include first of all, epidemiology, males equals females, and the average age is 64 for diagnosis. Now, risk factors, most common will be adhesions. Second most common risk factor for developing a small bowel obstruction are hernias. Additional ones are volvulus, strictures, including in inflammatory bowel disease, and Crohn's, and ischemic strictures. Also, prior abdominal radiation, cholecystitis, intussusception, foreign body ingestion, and any kind of intra-abdominal abscess. So anatomy-wise, the small bowel consists of the duodenum, the jejunum, and the ileum. The location can either be a proximal obstruction or a distal obstruction, and then the degree, it will either be partial or complete obstruction. So normally the small bowel is free of microbes, and that is not the case with the small bowel obstruction. So adhesions, inflammation, strictures, tumors, and foreign bodies all can alter the normal anatomy of the small intestine and cause weakening of the bowel walls and lead to dilation and edema. And then moving on to pathophys, you either have a mechanical small bowel obstruction or you have a functional small bowel obstruction. With mechanical, you have a luminal obstruction, and it's a decreased motility proximal to the obstruction, and air fluid levels will be seen on x-ray, and these need to be treated surgically. Whereas functional is usually a post-operative ileus or some kind of pseudo-obstruction treated conservatively and may or may not show air fluid levels on an abdominal x-ray. A mechanical obstruction leads to the progressive dilation of the intestine proximal to the obstruction and a blockage of the, proximal to the blockage, and then a collapse of the intestine distal to the blockage. When air is swallowed or when bacteria fermentation occurs, then gases are going to be released and collected in the bowel, and this will lead to distension and cause the bowel to be dilated and maybe even edematous, and fluid will leak out. And this could eventually lead to fecal emesis or any kind of electrolyte abnormalities, as well as necrosis and perforation. Clinical signs and symptoms. So usually a rapid onset of abdominal pain periumbilically, and then also colicky, crampy pain. Abdominal distension with a high-pitched tinkling sounds that eventually become muffled towards the end. Constipation or obstipation. Nausea, vomiting, focal tenderness may suggest ischemia. Dehydration and fever would suggest an abscess or perforation. So you can diagnose a small bowel obstruction with lab work and imaging. So your labs, you want to draw a CBC and CMP and arterial blood gases, serum lactate, blood cultures to verify that there's no sepsis or no infection in the blood. And then you confirm the diagnosis you confirm it with the CT, but usually you begin with an abdominal x-ray. And on an abdominal x-ray, an upright abdominal x-ray will reveal dilated loops of bowel with air fluid levels, proximal bowel dilation with the distal bowel collapse and a gasless abdomen. On the CT of the abdomen, it will reveal all the same things in addition to edema, ascites, whorl sign or coffee bean can suggest a volvulus, and then a target sign can suggest intussusception, and all of these things can be present in addition to a small bowel obstruction. Complications can include ischemia, necrosis, perforation, lactic acidosis, sepsis. Prognosis is good if it's a partial small bowel with no perforation. It's bad if it's a complete small bowel with a tumor or malignancy. Differential diagnoses include paralytic ileus, pseudo-obstruction, large bowel obstruction, volvulus, and you're going to manage this medically or surgically. Usually you're going to admit them to the hospital, preferably the surgery floor, monitor them conservatively with IV therapy, normal saline or lactated ringers, NPO, NG tube decompression, pain management with opioids, consult surgical oncology if you find a malignancy on the CT scan, and then refer to surgery if there's any kind of perforation, necrosis, or complete bowel obstruction. A conservative treatment will be more watching for 2 to 5 days with non-operative management with IV fluids, NG tube decompression. The only time you would give antibiotics is pre-surgery or if there's perforation. And then going back up to my PANTS questions to answer those questions, the first PANTS question answer is GERD management with PPI treatment is not a risk factor for developing small bowel obstruction. GERD usually involves the esophagus and the stomach and not the small bowel. And the presentation for GERD will be very different, and you will not see any what you would normally see on an x-ray with small bowel. Is very different. So GERD is managed with PPI versus GERD not managed with PPI does not make a difference for small bowel obstruction. The second PANTS question is, on an abdominal x-ray, you would expect to see air fluid levels in a stepladder pattern, and when the patient is supine, these air fluid levels are going to be parallel. When the patient is upright, the air fluid levels are going to be perpendicular, and they would present with constipation, abdominal pain, and distension, and they may also present with fever, nausea, vomiting, or any signs of dehydration or electrolyte changes. Thank you.